So it's my pleasure to introduce Andy Dwyer. Andy is the director of the Colorado Colorectal Screening Program. Andy has worn many hats in our community, and she's worked with Fight CRC. She also works with the Gastric and Esophageal Program at UC Health. And today she's going to talk to us about insurance policy and power of advocacy. So join me in welcoming Andy.
Okay, everybody. So I, like the last presenter, want to do a disclaimer. I'm not an insurance broker, but what I am is a super nosy, curious person who really likes to think about opportunities to help really think at the intersect of research, public health, and how to move the needle as it relates to access to care issues. And so I just want to say a huge thank you to many of our leaders here today, and then even Swati, who helped me with some of the slides that she had actually recently presented as well. So everyone, what I'm going to talk about again is that nexus of research, public health, and advocacy and policy. And one of the things that I just want to say is when I started really getting involved in policy and advocacy, it's because I really wanted to find a way to make things stick, right? We've heard this idea of sustainability, reimbursement, and it became very clear to me that policy was really a way to go. But access to care has always been one of the biggest missions in my career. So I think as we're hearing today, folks really have the discussion around colonoscopy every 1 to 2 years, epiendoscopy, skin exam. How am I keeping all of this straight? I have no family history of colon polyps, but I have to get regular colonoscopies since my 30s or younger because of conditions that I have. What does my doctor have to agree or always argue with the insurance company to get colonoscopy covered? And even my neighbor has a colonoscopy because it's preventative, but I end up paying high co-pays and high deductibles, even though my colonoscopy, because I have Lynch syndrome, is preventive. So what I want to say, everyone, is, of course, I think we heard that discussion, right? Every state's a little different. There's federal policy, there's state level policy. But honestly, folks, like these are the questions that we're really up against right now as it relates to Lynch syndrome and a number of health conditions. But when I was here about 2 years ago with a panel with Robin, Joan, several others talking really about this idea of advocacy and what are some of the things that we wanted to really kind of go in on, the idea of an ICD-10 code in Lynch to verify medical necessity and ultimately really verify determinative coverage for testing, for follow-up care. That's something that we really talked about. And one of the things I just want to remind everybody is that there's a number of health conditions where ICD-10 codes have been established. They've been set ICD-10 in terms of like the national standards, ICD-11 for global. But in terms of like just a specific example, even in the cardiac space, myocardial infarction, coronary heart disease, they have ICD-10 codes. And then ultimately, what ends up happening is ultimately medical coverage because of medical necessity that people end up having these sort of procedures, right? That are balloon catheters, that are stents. So again, having this code is a really big deal. So ultimately, right now, when we think about hereditary and genetic syndromes, there's a number of people who actually are able to get some level of coverage for genetic testing, medical necessity for follow-up colonoscopies and the like. Those are paired with CPT codes. But right now, there isn't anything that explicitly is Lynch. There's a variety of codes that are used. These are a number of those that are there that providers, others can use for basically showing that case. But it's a little hit and miss, right? Not everyone really knows how to utilize these codes. With some insurance carriers, they work for looking at genetic testing or even those follow-up colonoscopies that are needed for families, and not just survivors or those who have tested positive, but also for families. I think that discussion that we talked about with kids is a big thing, but also siblings, right? People who are part of the extended family. So one of the things that I chatted about when I was here about 2 years ago, and we had just started is with Fight Colorectal Cancer, a national advocacy organization that I work really closely with. We did, in the name and honor of Dr. Dennis Onen, created a really strong but small but mighty team of docs who were really interested, and healthcare providers that were really interested in definitely having an ICD-10 code specifically for Lynch and Lynch syndrome. So this is a group of the folks that are definitely engaged in this right now. We have a couple of additional members who've joined the team, but this is the original five, Fab Five, if you will, Swati in the middle, me to the side, Jen on the flanking on the side as well, but also Heather Hampel and Pete Stanek. And it's really an awesome team, right? Because it's from all over the country, medical experts who are part of a lot of different organizations, affiliations, and institutions. But the big fun part of this is this is the number of names of people and organizations who signed on, telling CDC, we need this code. So just as you can see, Swati actually helped format this slide, and that's very small print, but it's hundreds, right? As well as the big organizations and the like. So fast forward from 2 years past to here we are in January of 2025. So here's what was happening at that time. There had been changes in the federal government, changes in the leadership, and in January, at the turn of the year, we heard that it's anticipated that we would get a Z code to go forward. A Z code is not quite as strong as an ICD full code because it's more of a descriptor, right? It's information. You can use it. Sometimes people, it's not like a required. It doesn't have the same bang, right, than an ICD-10 code. So the Z code, right, we thought we were going to live with that. But ultimately, it was basically clear from the response that we had received from our different testimonies to CDC, the different hearings, they weren't really quite sure how to deal with Lynch syndrome because it had genetic causes, right? And if we start looking at a syndrome and genes and starting putting ICD-10 codes to that, what would be the ramification? What would be setting a precedent? So there was a lot of discussion. I think that was one of the big things. I think the other thing we heard from coders is it's going to be real hard, right, to look at all these genes, genotypes, and elect to really look at this syndrome at large. But I am happy to say that as we continue to move on, we continue to advocate. But one of the things that we actually thought was really interesting as we started to look is we started to tell this committee, like, yo, there is a slide for sucked into a jet engine, subsequent encounter. Raise your hand if you have that, know of anyone, or 3 steps removed. There's an ICD code for walked into a lamppost, struck by an orca, or any of those other animals. This is my favorite, unexpected situations, swimming pool of prison as the place of occurrence. So just to let you guys know, we just said, this is ridiculous, right? We even said to the committee, your chance of having Lynch syndrome is about as being common as a doctor or a lawyer, right? Like these are the things we're like, come on, this is crazy talk. So essentially, fast forward to just last week and coming up in September with Dr. Stanek as the lead, Swati, Jen, Heather, Bryson, people part of the CGA team, as well as this small group of people who are working kind of in memory of Dennis Onen, who really wanted to make the testing, really universal, find it strong in insurance coverage, really looking at these opportunities. With Pete really heading up that team with all of us behind him. In just a couple weeks, we're making another hearing to the ICD-10 committee with CDC. AGA is helping us. A number of other large advocacy organizations are behind us. And I am happy to say that the proposal for the code to cover Lynch syndrome, we're letting people know, of course, that it's a common issue, really. It's well established with widely available genetic testing. That this ICD-10 code would allow for better organization and implementation of clinical surveillance treatments, and that gene-specified ICD-10 codes would allow for a major step in research efforts, including nation-wide data sets, which I think we've heard about today. And our proposal has widespread support from the medical organizations and the like. So I'm happy to say we met with CDC, we met with their program officers, and we are very optimistic that come in a couple weeks after the September hearing, that there's a very strong likelihood that Lynch syndrome will be a designated ICD-10 code moving forward with the specific genotypes behind that. So anyway, the fight, yes. But I want to remind everyone, the fight is not over. We are going to continue to look for ways to advocate. I do think really spreading the word, we'll hopefully with Fights Here, see and a couple other groups continue to give everyone a heads up about this issue. But if and when this happens, and again, cautiously optimistic, this will be amazing. I also want to say that with the ICD-10 and Lynch, there's also some discussion of Leaf-Fermini, as well as maybe BRCA also coming in. And so maybe as sort of an idea of this genetic and hereditary opportunities, we'll see a Lynch syndrome, but several other conditions really start to move the way and get past what I feel like feels a little prejudice around genes and ICD coding being kind of an issue moving forward. I just want to also say that, there's some wins. We're ultimately, still continuing to look at the opportunity for the United States Preventative Services Task Force to ultimately look at Lynch syndrome as an area of coverage. As you know, USPSTF really does make recommendations around preventive cancer screening, and many cancer screenings with a grade of A or B. Those are typically what's reimbursed from insurance companies and the like. There were some special sessions ultimately talking about as even a risk stratification if Lynch syndrome was designated with USPSTF, as there's been some other precedent, is this something that could be set? So unfortunately, I think, Swati, this is in 2022, 2023 period of time, ultimately, that ultimately all the task force did take on, just ultimately hearing about this, really thinking about these opportunities. The idea is ultimately not at this time. And we need, in terms of having a designated research plan, to think about moving this sort of an idea forward. That has not happened, unfortunately. So some work to move ahead. And what I want to just say, and I'll talk a little bit, is the current administration, as we've discussed, that it looks different. And what the USPSTF composition will look like, how the current Health and Human Services team may be making decisions. It might be looking very different than we've known, what we've seen before. And so I think as advocates and as healthcare providers, we're keenly aware of this, but I think the patient community needs to be aware as well. So in terms of also some wins, I just want to also say, particularly for colorectal cancer, I'm just reminded everyone that nothing typically happens overnight. Even some of the follow-up colonoscopy issues where there's oftentimes need for Lynch syndrome, families and patients to have follow-up, for 10 years, we fought for these sort of things. We have to stick with it, really thinking about ultimately some of the advocacy groups, ACS, Fight CRC, AGA, many of the advocates in this room. The idea of really looking at helping advance these sort of opportunities so patients aren't paying out of pocket costs for what is typically starting out of a preventive screen. These are things that are going to have to continue on so we don't have issues related to copays, high deductibles. And ultimately, I just want to say that these are some examples of some wins in terms of this follow-up colonoscopy, because we did see Medicare, Medicaid, ACA compliant plans that are in the insurance and private insurance space. But ultimately, then there's still some opportunities because the uninsured, grandfathered, and ERISA plans are ultimately excluded. So I wanted to say, as we continue on as a community, and I think really considering these out-of-pocket costs, the copays, hopefully having this ICD-10 code, more established medical data, and being able to move forward, we'll really be able to use what's been said as kind of the foundation for patients moving ahead as well. The other thing I wanted to highlight, and this is again one of Dr. Patel's slides, is ultimately the ACA, right? It's a very big deal. And ultimately, as USPSTF stands, that ultimately, even as we're seeing recommendations such as screening that are mandated through insurance coverage for average risk individuals, that's making a big impact. So even if you look at the ACA, you look at the number of people screened over the period of time based on USPSTF guidelines, ACA coverage with no cost sharing and the like, we see that trajectory moving forward. I want to say, though, that ACA, though, by average risk population, I think has allowed some great opportunity for Lynch patients, others who are high risk, to also be seen. That this is something that we're going to have to continue to really preserve as we move forward and really thinking about advocating for this kind of work. And I would say that even in the medically underserved, really continuing to think about how people who have Medicaid or uninsured, how do we really continue to look at access and opportunity? And of course, you see in the 2021, 22, 23 period of time, ultimately we see a little bit of dip in screening. And that's just a reminder, everybody, the guidelines changed, right? From that 50, starting at 45 years old for colorectal cancer screening, which is a bit of the exemplar today, but a reminder that when we see these guidelines change, when we see policies change, when we see insurance coverages, this is the kind of stuff that happens, right? We ultimately see screening increase even in the hardest reach populations and those who are most in need. So I want to just say that I use this as a bit of an example because I was one of the people, along with many in this room, who helped advocate for looking at guideline change, for looking at USPSTF, looking at American Cancer Society to make a change, which all was impacted by policy, to start screening people who were younger than 50 because what we knew of incidents and help move that forward. But just a few weeks ago, the American Cancer Society sent out data that ultimately, as you saw that trajectory of people moving forward, for those who are 45 to 49, from ultimately 2021 to 2023, we saw about a 33% increase in screening. Rates remain relatively stable during the same period for those who are 50 to 54. But in terms of cancer diagnosis, we saw a sudden pickup of localized cancer diagnosis among 45 to 49 in this period of time. So I just want to remind everybody that as we start to see these policy implications, we start to see this covered in insurance starting to move forward. This is a huge thing for what it means for us to really look at finding, preventing disease, and really quality of life. I want to just say, for those of you who don't know, ultimately several months ago and in the last year, there was a court case that came to the Supreme Court of the United States, and it was Kennedy versus Braidwood, where ultimately there was a discussion about removing guideline and preventive care out of ACA. And so I'm happy to note that ultimately that did not pass. And so right now, including preventive cancer screening, and the decision was made just actually a couple of months ago to continue to keep this. And so everyone is considering this a win, right? So preventive cancer screening, really even also continuing to really look at what I think is allowed for hereditary and high risk has kind of tailed in with that. It was at risk. So the Supreme Court has ruled to keep USPSTF included in the ACA. But the bad news is, and rumor has it, which just made me think about the Fleetwood Mac Rumors album, that the rumors is that unfortunately we have to monitor the situation with USPSTA and prevention because ultimately there is discussion even coming up this week that the task force may look very different. And so all the people who are currently task force members may be removed, and there may be new people who are put into play who may be making very different decisions about what USPSTF will cover and then ultimately what ACA can pay for. So I want to remind everyone, I am not a policymaker. I am not an insurance person. I am a busybody. So come with me. Let's keep rocking because there's always a bright spot. So what I want to say is all of this is really happening at the federal level, right? But we heard of this in Colorado. We heard what was happening. Several states have heard this too. So I'm happy to say last legislative cycle, with the help of the Chronic Care Collaborative, the MOLICA, our state leaders who are congressional and ultimately Colorado's legislatures, we said regardless of what the feds do, we are making sure in Colorado that with our Department of Insurance and our plans, that preventive health care services will be covered. And that, to the other gentleman's point earlier, is a state mandate. So we're really excited this is going to cover. My plan is to really continue to speak to these healthcare providers, to these legislators and healthcare providers, not just about what's happening with the general USPSTF guidelines for colon, for all the other cancers for screening, but also say like, hey, we got to keep a keen eye on Lynch syndrome, people who are vulnerable, really can continue to really think about how do we look at this expanded coverage in Colorado and within our states, even if the feds make different decisions. So one of the things I just want to remind everyone is I do think FORCE, Fight CRC, I know Jacqueline's Foundation, I know Live and Kickin', many folks have amazing resources that if you are in a bind, where your insurance is denying, talking to your provider, there are a lot of great resources. And I will say, I do think with a little bit of education, a little bit of persistence, you can usually get those colonoscopies covered, reduced rate, as long as you're educating, working. And unfortunately, right now, it still takes that advocacy, but there is a lot out there happening, and I think a lot of resources to support us. And JJ, who works closely with Fight CRC and a number of folks, just reminds me that sharing your story, sharing that insight can make a big difference. So I've talked a little bit about the coverage, talked about the opportunity as it relates to Lynch syndrome, and I think the way that we can go for covered benefits, for opportunities, we have a lot of work to do, but never underestimate the ability of a small group of committed individuals to change the world. I would have to say this is probably one of my favorite quotes, because anything that I have been involved with really does start with a couple of very committed people, and then the masses follow. That's what we really need to have happen. But if you think, even in a small group, that it takes a bit, just remember this. If you think you're too small to make a difference, try sleeping with a mosquito. So I just want to say, I would have to say, I'm a mosquito. You can be a mosquito. We can work together. There's a lot of great work. We're up against it. I think Swati said this earlier, we have to double down, but there are some amazing things that happen. And in the time of peril, there's really a lot of things that can boom, and I think we'll be better for it. So I just want to say thank you for everyone who've been a part of this work, letting me steal some slides, Dr. Patel, and then all of you. I just am so amazed and excited. Every year this thing grows, and I'm just so excited to be a part of it, and thank you for having me.
So Andy and Cami are coming up here to answer any questions that people might have. And
so I thought it was really heartening to see that the legislature took action in the last session. I'm wondering if there have been any discussions with the legislature about working with insurance regulators in Colorado to prevent discrimination in life insurance.
That is a great question. I actually, as you were presenting, I was thinking about that a little in terms of like, what does that look as well? I don't know, but I can find out. And I do think it's probably an area that, needs extensive help and work. Danielle, I don't know with Fight CRC or others if this has been an issue that has come up. I do think, though, to your point, at the state level, it could be easier to have those conversations. So the legislators who are listed, that is a keen group who I think we can meet with individually, ultimately through our state cancer coalition, the Chronic Care Collaborative. I'd be happy to bring this up, see what's done, and if there hasn't anything, we could definitely set a coffee and chit chat.
So we have been using a Z code that was provided by our colonoscopy provider. We've used it, I think, about 9 times, and it's gotten it so it was considered coded preventative. And what we use is Z12.11. I don't know if you've heard this or not, but they said, so every time we go in, my sons and wife.
There's 3 of us.
Okay, 3 of you. Okay.
So we hand them a note, a sticky note, and put it on the chart and says Z12.11, encounter for screening, not diagnostic.
Mm-hmm.
And I don't know if you've heard that or not, but that has worked every time.
Well, what I will say is this, the codes that I listed, I know that those are codes that can or have been used. Swati and others might know, other providers might know which one. I think there's variability, in terms of like what people will and won't take. If you find something, but I think, sir, this is amazing. You found out, you've advocated, we found something. I'm hoping that in the future with these ICD-10 code for Lynch, it will be a one-shot wonder that won't hopefully have to be, but good on you for doing that. That's amazing. And again, I do think, as I can tell, and I know it's variable, but a lot of times for certain private insurance plans versus sometimes Medicare and Medicaid, they've been a little more apt to take the codes that are sort of that general susceptibility genetic but it kind of is hit and miss. And I think for every time I would say that was true, there are 3 other examples where that's not true. But do any of the other providers want to speak? Because I live this in the policy and helping advocate, but what plays in the medical office? Swati, do you want to share?
It can be a moving target. There are some insurance companies where you can use the same code every year and it's reliably covered, and then others that just change it year to year. And oftentimes, I don't mean to call out Leslie Van Nostrand, but many of you know her. She is the mastermind behind our clinic. There are these frantic, urgent calls a day, 2 days before the procedure, because that's when the insurance company tells us the code is not going to work. And they require, a clinician to peel away in the middle of our endoscopy schedules to make a phone call to get it to be covered. It's just these barriers that really shouldn't have to be there. If you do find out a code that works for you in your system, please share that with us. We oftentimes put in the Z code that you mentioned, but we have, some insurance companies that literally I know every year a patient's coming in, I'm going to get a phone call, and I block out time knowing that I'm going to have to argue.
I was just Googling while Andy was talking, because I was like, I know that when I see a patient, I can put in a Lynch syndrome code, but I'm putting the Z15.09, which is the same one for any single mutation of any gene. So it's not specific to Lynch. Although I will say that this is not a unique challenge. As you mentioned, there's some other conditions that have some of the same challenges. The Lee Framini Association has put out some really nice, like, how to deal with an insurance company patient resource. I think it's lfsassociation.org if anyone wants to look at their resource and can kind of translate it for Lynch syndrome. But there's a lot of help out there too.
And I would say I had an example of Force, right? They had even patient templates, but and then I think even as I walked around today, there are some incredible resources here about how to have a conversation with the doctor, how to really make sure to bring this to light. And to your point, some of these foundations, Force, the Lynch Society, I know even Alive and Kickin', and then Jacqueline in the foundation with Joanne, there are some amazing real resources, to your point, that are ready to go, and use those to the fullest degree while we get this ICD-10 thing taken up, because next year or 2 years from now, that thing is going to be done. So hopefully.
I'll stand up. Hi, I'm Amy again. I've been involved with some policy work with like AAFP and our CAFP. One of the things that I noticed as a patient when I initially got my diagnosis with Lynch syndrome, I went in for BRCA testing. I think that was one of the options that was mentioned of how we ended up here, because there was prostate and ovarian cancer that ran in my family. And I was able to get it covered because BRCA specifically is called out in ACA as being covered by insurance, whereas Lee-Fraumeni and Lynch syndrome and many other heritable cancer genes are not required to be covered under ACA. So I was wondering if there was any movement towards getting genetic testing more likely to be covered, just as a matter of like equity for everyone.
Yeah, and I think with the ICD-10, that is really part of the thing, is really making sure that there's information around the condition, more data around what was considered like research for the implementation. That's really the hope that ultimately with this code, that's medical necessity, that we can also then not just look at the colonoscopy coverage, but ultimately the testing coverage as well. So that would really be, the name of the game. It will, I think, in terms of the implementation, right, and making sure this sticks, and that we continue to make sure that this ICD-10 code yields that, kind of ultimately the data that will lead to that. That's going to be a part of the piece that we're looking at as well. But I do think, there might be some other additional type of opportunities that we look for, but hopefully ICD-10 is one of the things that really moves that. But I don't know if anyone else has any.
I was just going to add, I feel like the two different things, like testing based on ages of diagnosis, family history, and so forth. Genetic testing for Lynch syndrome, I feel like that's very rare that we have any struggles with getting that covered. They follow the NCCN guidelines, and same thing for these other conditions. And I think these ICD-10 codes, I think it's the screening, it's the colonoscopies, I think it's those things that's really going to help. And then answering all the research questions that I think we're all wanting to understand better, like different risks, different genes, having that information there. So I think we have time for one last question and then go from there.
My question is just one for clarification. So having a colonoscopy screening approved under preventive services provides you get access to the service. But then if a polyp is found and removed, then it becomes a service that's not preventive. If this changes to, and we get an ICD code, does that removal of the polyp get included under preventive services, or would it still be subject to deductible and coinsurance?
So the follow-up colonoscopy bill is supposed to have actually eliminated that totally. If that is still happening in terms of what is supposed to be mandated, that is actually probably what should have actually been taken care of in 2022. So the whole idea is that if you come in for preventive screening, have a screen, and something is found, that shouldn't necessarily ultimately, for anything that's found as a result, there shouldn't be diagnostic charges and the like. There are resources as well, because that's something that was mandated even at the federal level. So in terms of looking at that, the ICD-10 piece won't necessarily, I think it will help for the medical necessity for the colonoscopy, but as far as the polyps, the follow-up polyp and ultimately what was mandated should actually be covered. Yes. So that was kind of what they call the, part of the loophole. So, and I'm happy to share information. And I think then to your point, I mean, the resources that others have related to information to be able to follow up, that's something that we want to ensure that people have while these sort of opportunities. But what I will say, folks, is I do think that the insurance coverage, there's, recommendations, there's policy pieces that have to play. It does take a period of time, but I do think if we continue to stick with it, advocate, make people sure that they're aware of what's currently covered under the prevention piece, and then really continue to advocate. It sometimes doesn't happen overnight, but we'll get there. And so I really do love everyone being here, because as these opportunities happen, I think through Dr. Patel, through the genetic and hereditary and directors here, we can share information where people can share stories, advocate for opportunities coming forward if they're a really good fit for your work. So.
Thank you both so much.